Dr. Issam Moussa has a theory about how the brain and the heart influence one another. But until he joined Carle Foundation Hospital, he wasn't in a place to fully explore that theory, but now he can really get to the heart of it. We'll share his findings so far today on Being Well.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
Carle is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carle, with Health Alliance, is always at the forefront to help you thrive.
Thank you so much for joining us today for Being Well. I'm your host, Lacey Spence, and today we are talking about a connection between the brain and the heart. Now, joining us today is Dr. Issam Moussa from Carle Foundation Hospital, and welcome to the show. You're a first-time guest.
Thank you very much.
Thank you for being here. And if you could, give us a little bit of background about who you are.
Yes, yeah. So I've been practicing cardiology for about 25 years. I'm originally from Syria. I immigrated here about 30 years ago or so. I spent most of my career in New York, New Jersey area, was predominantly in academic medical centers. And my career sort of evolved from, in the beginning doing clinical work, caring for patients, and doing a lot of clinical research. And then I took a sort of my MBA to transform to sort of management of healthcare. And obviously I continued to be doing research, clinical research and translational research.
And so you definitely wear a lot of hats. What made you want to go into the medical field?
I was like 6 years old. Really, there is no sort of a one aha moment. It's one of these things that I like biology, and really there's nobody in my family or there's a single event that triggered that. Just I like biology, and that was kind of, in a weird way, the only thing I considered, believe it or not.
Oh, so once you've been in it, do you find that there's a lot of things that you enjoy about it, whether it's helping people or making a difference?
Yeah, absolutely. I mean, obviously, the main reason why medicine exists is to help people, right? But I think, these days, as you know, we can't help people well without finding the causes of disease and finding treatments, right? So research has become really a part and parcel of what medicine is too. So I enjoy both caring for patients as well as finding out what causes disease and how we could best treat it through research.
Definitely, and it feels like every day you see a new headline of more research, new findings. The medical field is just changing so rapidly.
Yeah, like everything else, right? I mean, electronics changing science. So science over the last, I would say, 50 years, obviously with the technology in its all shapes and forms, have been kind of very rapidly progressing. I think obviously medicine and biology is not an exception.
And so today we're talking about the connection between the brain and the heart. A little bit of distance in between them, but yeah. What inspired this research?
Yeah, so obviously, I think medicine in general is organ-based, right? So you hear, brain doctors, heart doctors, stomach doctors, right? And obviously this is done because the field is so complex and you need experts that know exactly that organ to treat it best. The problem, however, we know that there is nothing that's separate in the body, right? The body is all connected, and obviously every organ affect each other, whether you're healthy or whether you're sick. So really, I think for the last 100 years or even more, that medicine has focused on the body as separate organs in terms of how the specialization expertise is. And I think obviously it stands to common sense that the body is connected, and we need to look at it in a connected way. So I'm a cardiologist, right? I do cardiology for a long time, but there's a lot of cardiac diseases that we know it has to do with the brain activity, right? Directly or indirectly.
Okay.
And obviously that can happen at every level. I mean, the heart obviously pumps blood everywhere, right? So the heart is connected to every other organ in the way that it's a pump. But also the heart have nerve cells inside it too. And these nerve cells obviously connect the heart itself as well as connect the heart and the brain. And those nerve cells must have a function. Just because it's difficult to see these cells and to sort of do tests to evaluate how they function, that whole field been dormant, right? There haven't been a lot of sort of findings that enable us to be able to influence that system. And you could go, you've heard about people doing meditation, right? And slowing their heart rate. Or you felt obviously when you see something that's kind of producing emotion, you feel your heart is going fast, right? So
when you get nervous.
When you get nervous. So there's lots of things that we sort of don't necessarily think about it as to why, but these are the very simple things. There's a lot of things that kind of more had to do with psychiatric diseases or emotions or even brain diseases that the heart may be part of a cause for it, and vice versa. There's cardiac diseases that's coming from the brain, and there's nothing wrong with the heart, but the way the brain functions, and it secretes a lot of special hormones that could make the heart beat faster. So there's really a very complex relationship, and it's both ways. So when I really got started, sort of interested in the topic about 3 years ago. About a year and a half ago or so, there's a group in UCLA that really been doing this sort of research for over a decade, and I visited them and again got a more understanding of what the science is, and that kind of determined to establish this sort of field of research at the University of Illinois and Carle.
Yeah, it's definitely amazing to see something that might normally be somewhere more metropolitan come to, I don't want to say the cornfields, but you step outside to Champaign and that's all you see for miles.
Yeah, true.
And so what's the importance of bringing this type of research to Central Illinois?
Yeah, well, clearly, the reason why it's possible, right, because there's that combination. You have the university, which is in basic science and engineering and neuroscience, it ranks very high. So there's a lot of talent in the University of Illinois when it comes to the basic sciences and research and engineering. And obviously, Carle as a health system also serves a lot of patients. There's a lot of good clinicians, and now we have the College of Medicine that attracts even more talent. So having the combination of those two entities really make it possible to have both the people and the technology and the funding to be able to do this sort of work that, would think it metropolitan, right? And there's a lot of institutions that are not metropolitan. They're doing similar work, and obviously, again, at the end of the day, it's really the vision, the people, right, and the ideas, and things can happen.
And so are you working with UCLA, or did you just bring a similar program here?
No, obviously we're working more not directly at this point, right? So this is just kind of more having a collaborative relationship in terms of exchanging concepts, but we don't have any direct project we're working on together at this point. They may be in the future, but not at this point.
And are you able to share what concepts you're kind of exploring? You went into it a little bit, but anything new and exciting?
Yeah. So one of the things that when people have heart attacks, typically it's known that if somebody have a heart attack, they have very high risk of getting depression or anxiety, whether the first year or even years after. And people used to think, well, okay, if somebody have a heart attack, that means they become anxious, right? Have heart problems. So that sort of anxiety would kind of lead to depression and things like that. So kind of more external, because of awareness that I have heart trouble, I become depressed. It may not be the case. Maybe actually that the heart, having had a heart attack, the nerves in the heart or the hormones the heart produce actually affect specific brain areas that the brain itself may change chemically and cause depression. This is a theory, right? So this is the theory we're investigating, that how does a heart attack lead somebody to have depression? So the way we're doing that, we're obviously gonna, when patients come with a heart attack, right, we're gonna do a battery of different tests to check their sort of standard, where they stand in terms of their cognitive function, overall feeling, do they have depression at this point or not? Mm-hmm. Then we're gonna follow them for about 2 years, and again, repeat these batteries, but also we're gonna do a special brain MRI. It's called 7 Tesla. So 7 Tesla is obviously the power of the magnetic field. In Illinois, there's none, right? Or in the US, maybe there's 10. It's a very kind of advanced technology, mm-hmm. and it's to have very high resolution, that it would allow you to see things in the brain that prior technology couldn't. So we're gonna use the 7 Tesla MRI to also look at certain areas in the brain where we know that depression could come out of if it malfunctions, and to see whether we see a difference in the brain, at point 0, meaning when the patient just came in, versus 2 years, in addition to other blood tests. So we're trying to see whether there's structural changes in the brain because of the heart attacks that led to depression or anxiety or similar disorders. So this is one project that we'll be doing.
And so let's say you get a couple years down the road and you realize that there is that connection. How does that change how you treat patients?
Yeah. So there is now already devices that modulate, or I would say affect the signals between the heart and the brain. And one of those devices, people could use it for pain, they use it for many other diseases. So there are ways now to actually interfere with the signals that are sent from the heart to the brain or vice versa. So theoretically, if you have that technology or a new technology, because really first, if we understand the mechanism that could lead to even new technologies to be able to interfere or modulate that signal.
Wow. And so would that also impact if there's like the hormone, I think you said, were released?
Yeah, so obviously the hormones, right, so there's 3 ways, again, the heart interact with the brain, right? Again, we talked about blood flow, right? So if the heart doesn't pump blood to the brain suffers. So that already known, right? The other component, that there are hormones excreted from the brain, from the heart or other organs that circulate in the blood. And if there's a heart trouble, those hormone levels go up and down, right? And then they circulate in the brain. So this is the hormonal connection.
Okay.
Now we're talking about the neural connection, meaning electric signals, right? So the electric signals are what are we investigating. Obviously, electric signals, when sent from the heart to the brain, also can make the brain cell produce special neurotransmitters or neuromodulators. Also, those are type of proteins that have a function. So I know it's kind of, may look complicated, maybe it is complicated, but we're looking at how the nerves affect that interaction and what do they do to the brain, both in terms of electrical stimulation as well as what sort of proteins they encourage the brain to produce that can have sometimes bad effect or good effect, depending on the specific signal.
And so if it was a good effect, how could that kind of present itself in the body?
Yeah, that's a little bit generic question. So in a sense, there's clearly that the emotional responses, whether it's stress or happiness, being relaxed or not, that when you perceive those feelings, that have a direct impact on the heart by either slowing the heart rate or making the heart rate faster, making the heart pump slower or faster, right? So all these perceptions are transmitted to the heart and the heart reacts, right? So, in the old days, 3,000 years ago, people used to believe that the heart is everything. It's the soul, it's the, right? And now we're going back to say, is the heart only a pump, or actually those nerves in it that connects it to the brain makes it have functions that we weren't aware of. But at the least, that anything really happened in the brain in terms of anxiety or stress or relaxation, etc., is automatically reflected by how the heart is functioning, both in terms of heart rate and pump.
And so as you're studying the connection between the heart and the brain, is there anything else that you're looking into, or even just around the country that they're looking at?
Yeah, there's
heart
really
being
many.
connected to?
There's many projects. I mean, the group in UCLA, they're looking at how the brain, what is the brain role in causing heart arrhythmias or heart rhythm problems? Because the brain sometimes, if it secretes this hormone called catecholamines, it's a hormone that stresses the heart and causes irregular heartbeats and things like that. Others are investigating, and this is more really a new line of research, how does the heart affect the brain? So obviously depression is one of those things, but also sometimes there's some research that people with Alzheimer disease may have the same genetic changes happening in the brain and the heart, and that could cause electrical problem in the heart. We're looking at one of the things is brain trauma, right? And when people have brain trauma, some of those patients actually, their heart gets weaker, and that even within days, right? So this is not cardiac disease. This is heart disease that happened because the brain has been sending very intense signals, not good signals, to the heart that make the heart muscle weaker. Even like seizure, people with seizures could die suddenly from the heart, right? Even though it's seizures. So there's really multiple, it's a very broad field, but I think, the way to think about it is that, there's how does the brain affect the heart? And there's a lot of that is known or being researched, but how the heart affects the brain neurologically, this is where still there's not a lot of work, because that sort of work is difficult to do, right? There's no test in humans that we could, take a picture or do a test that we could see those nerves. That's why it's difficult to do. So it's mostly in animals, and it's just beginning.
And so with your research, how long does it take before you can, and it might vary, but before you can put together, reports that are fact-checked by the industry?
Yeah, well, obviously, this specific depression protocol, we need 2 years, right? So this is kind of, we need basically to go through the study. And that would be still, it's a small study. I mean, those studies are, any new study is more generates hypotheses or questions. So you say, gosh, we've seen something that may suggest this is what's happening, right? But for that to be confirmed, you really need to do more studies. You need to go back to animals and test the hypothesis to see if it's true, right? So any new field, it's a journey, a decade or more, that you really, when you get to information that's solid and it can be used.
So where are your sights set? Are they still within this decade looking at this, or do you have any other areas of study that you're interested in?
Yeah, I mean, there's others, but one have to focus, right? So I think I find this area is very sort of interesting, and it's still in the beginning. So there's a lot more to discover, and obviously it's a difficult area for research, so it does need a lot of time and focus.
And so you were talking about your colleagues at the University of Illinois that are able to assist you with this. What are their kind of backgrounds? Are they all medical professionals? What does that look like?
Yeah, no. So there's multiple disciplines. There's bioengineers, right? There are neuroscientists. There are cell biologists, and there's imaging specialists. So those professionals, none of them is necessarily physicians or medical doctors, they're PhDs, right? So each discipline focus on different study, because obviously when we study heart-brain connections, you need to look at cells, you need to conduct electricity, you need to image, you need to design things, right? So all these are basic science research, really in the field of more science rather than medicine particularly. Now there are physicians who are trained basic science research that do both, but often really it's separate professional. That's why you need multidisciplinary team to be able to get the right people on the team.
I was going to ask, I mean, how important is it, how invaluable is it to have folks from different perspectives on one project to, I guess, kind of carry you through?
It's very, I mean, number one, it's necessary that you cannot do it in any other way. Mm-hmm. But number two, you really learn a lot, right? Because you get these multiple experts, and they obviously have deep expertise in one area, but they don't know enough about the other, right? This is why when there's multiple experts, they could do more, because they could easily fill the knowledge gaps in any given topic that you're researching.
So on a typical day, you might have the bioengineers go ask you questions and vice versa.
Yeah. And you have obviously meetings, weekly meetings to discuss and look at journal clubs and research articles and decide, how do we begin the experiment and things like that. So yeah, there's obviously constant interaction and ideas that also wasn't on the table that would come through by having these discussions, right? So these discussions not only to, I would say, explain or talk about one project. As we're discussing things, typically new ideas come from that discussion.
And I know you were talking about the technology being huge for this research. Can you talk a little bit about that piece of machinery?
Yeah, well, that's not only one piece, right? So the machinery is obviously there's, I talked about the 7 Tesla MRI, right? Yeah. This is where you see the brain in ways that you couldn't have seen that before in humans. Also, we're going to have access soon next year for like a 9.4 Tesla, right? But this is more for small animals, because obviously any questions often you would need to do experiments in rats, and we have a technology to really help us do that. There are experiments related to microscopes. We're going to go and look at this cell in the heart that's probably more 5 microns or 10 microns. Well, how are you going to see that, right? So there's many different kinds of microscopy. Some are old and known, light microscopy, electron microscopy, but I don't want to go into the detail, there's many different kinds of microscopy that are needed that would show you not only the form of the protein or the cell, but you could tag it in a certain way and you could actually see different lights in cells. So the technology is, again, that's the one reason why progress has been steep, because the technology now we have enabled us to see more and understand more on the kind of not only cell level, but on the DNA level and on even the atom level in electron microscopy.
And in talking about the technology, are there any gaps or anything that you would like to see technology develop to really help out this research?
Yeah, I mean, obviously, ultimately, what we want our technology to be able, in a human, non-invasively from outside, to take a picture or to do a measurement that tells us how is the system working in terms of this a nerve connection between the heart and the brain in multiple diseases. Now we have a lot of imaging. We look at the heart muscle, we look at the blood vessels, we look at the valves, we look at the rhythm, right? So we have a lot of testing for everything except looking at those nerve cells in the heart and how they connect. So the ultimate purpose of this is to get to a stage that we have in humans some testing mechanism that we could actually see and understand how the subsystem is functioning. That will take a long time.
Oh, definitely. And as we're in our last couple of minutes, what would you like to share with our viewers at home that maybe they wouldn't think of that goes into the research you do?
Yeah. Well, I think, the research at the end of the day need to answer a human question, right? When people feel that always, they form an opinion or they have an emotion, they feel it in their heart, right? Mm-hmm. So I'm saying,
like a broken heart.
A broken heart. So there is actually a broken heart. That stress, or in some people, could actually cause heart muscle damage within hours. In some people, right? So really the key here, this question is not esoteric. It's not just to discover things that had nothing to do with people. Actually, it's at the core of how we live our lives every day. There are very simple questions that we don't even ask, right? Why do I feel? We'll talk about love, hate, any emotion that you always think here and it's here, but I don't know, maybe it's here, maybe both, right? Mm-hmm. So I think this research will have implications both for the human behavior, how to stay healthy by understanding how to modulate stress, in addition to actual diseases, right? So it could have implications for both health and disease.
And so we've definitely learned a lot today, a lot to process. So thank you so much for being on our show today.
Absolutely. Thank you for the opportunity.
And in our next episode, we're actually going to talk with Dr. Graham Huesmann, also from Carle, who is doing some similar research with the brain and also using the 7 Tesla MRI. So very cool. So be sure to stay tuned for that. And today we are joined by Dr. Graham Huesmann of Carle Foundation Hospital in Champaign-Urbana. Thanks so much for coming on the show.
Happy to be here.
And so you are a first-time guest with us. So if you could, can you give us a little bit of a background? Why did you get into what you're doing?
Sure. So when I was an undergraduate, I didn't know what I wanted to do, research or medicine. And so I put that decision off for many years by getting both an MD and a PhD at the University of Illinois. And then specialized in neurology because my PhD was in neuroscience. Had the opportunity to do that neurology training in Boston at Massachusetts General Hospital, and then stayed there for a fellowship in epilepsy and a postdoc. And honestly never thought I would come back to Illinois. But the opportunity to participate in the new med school that they have here, the amazing support that the hospital has for research, and the great collaboration between the university and the hospital was just too good of an opportunity to pass up. And it turns out I actually really missed Champaign-Urbana because the traffic in Boston is horrendous.
The traffic?
Yeah.
Yeah, all we've got around here is cornfields, far as the eye can see.
Big sky.
Yes. So as we are diving into today's topic, can you first start by telling us a bit about, again, where this research is being conducted and who's behind all of it?
So it's actually a great example of the collaboration that goes on between the university and the hospital. Doing big projects like this, big expensive projects, would be hard for one person to do alone. And so collaborating together makes opportunities like this possible. So it's a joint venture between the University of Illinois and Carle Foundation Hospital to purchase this 7 Tesla MRI machine. One of the exciting things about this collaboration is that it's not just a research tool. There are other 7 Tesla machines in the country, but they're all housed in research facilities. And with this collaboration, this 7 Tesla MRI is going to be housed at Carle. It's going to be a clinical machine, which means that we have the opportunity to use it as a clinical tool to order patients MRIs on the 7T and make clinical decisions. Previously, or at other institutions where I was before, if I wanted to order a 7T, I had to find a research study that the patient fit into in order to get it, because insurance wouldn't cover it since it was a research tool. So it's a huge opportunity, and it's only the 6th one in the country to be housed in a clinical setting, to be available to be used as a clinical tool, which is very exciting.
And so as we're talking about the 7T, what makes it so groundbreaking?
So MRI machines are just magnets. They're just big magnets. And the T, or the Tesla, is the unit of measurement of how strong a magnetic field is. Most MRI scanners, when people go in to get an MRI, it's a 1.5 Tesla. That's the unit of strength of how strong the magnetic field is. Here at Carle and other places, there's also 3 Tesla, which is a little bit stronger. And the stronger the field, the better the picture you get. And then 7 Tesla is just an order of magnitude better resolution. The stronger the field, the smaller the structures you can see. And for me, clinically, I specialize in epilepsy, and a lot of the things that go wrong or change in the brain that can become sources of seizure are very small. And we just don't see them on 1.5 Tesla or 3 Tesla, but they are seen on a 7 Tesla. And that opens the door for significantly improving the treatment of those patients once you can find where the problem is on an image.
Unfortunately, a lot of people maybe are familiar with epilepsy, and maybe in some cases they aren't. Can you kind of explain what that is?
Sure. So the basic, simplest definition of epilepsy is anyone who's had more than 2 seizures in their lifetime. It's a very easy diagnosis to get. And a seizure isn't necessarily what we think of in terms of a Hollywood depiction of a seizure. It doesn't have to be falling down and foaming at the mouth and shaking. It can be focal and just one small part of the brain having a seizure where the person just loses a little bit of attention or loses a little bit of time. Doesn't even have to be any shaking with that. But every time that a seizure happens in the brain, it actually injures the brain a little bit. And if seizures are uncontrolled, over time, the brain gets injured more and more and more. And then whichever part of the brain is involved as the onset of the seizures, that starts to lead to dysfunction. So if the seizures are coming from the part of the brain that allows you to make new memories, over time, you have a much harder time making new memories. If it's coming from the part of the brain that allows you to make executive good decisions, like not say things or not do things that might be inappropriate, over time that becomes traffic. Exactly, yeah. So stopping seizures, controlling seizures is important for long-term quality of life. And that can either be done through medications, which is how most people respond. And then if medications don't work, then we can consider surgery and actually take out the part of the brain where the seizures are coming from. And that's where having a 7 Tesla makes a huge difference. In patients who are candidates for surgery, if you can't see where it's coming from on an image, they're called non-legional. Lesion just meaning any spot that's not normal brain tissue. And the success rate for non-legional surgery is very low. It's like 20 or 30% are seizure-free after the surgery. But if you have a lesion, if you have a spot to go for, then the success rate is much higher, 60 to 70%. So that makes a huge difference in the quality of life and the outcomes from the interventions we might have to do or be able to do.
And so that's where this machine can come in. It can help you pinpoint.
Exactly.
Gotcha.
Exactly.
And when talking about epilepsy, what age range are people affected? I assume it can be a wide variety.
There's actually sort of an inverse U curve in terms of risk for seizure that starts high in childhood, drops down a little bit, and then it goes up again as we age, getting into the 50s, 60s, 70s. A lot of the causes for seizure in young people is genetic conditions, genetic predisposition to having a seizure, brain malformations that may have occurred in utero during development. And then the peak in later years is due to structural changes that we acquire over time. So having a brain injury, having scar tissue in the brain, that scar tissue can then become a source for seizure. Having a stroke can become a source for seizure. Having something growing there that's not supposed to be there can become a source for seizure. It really affects every age. And I guess thankfully for a lot of the pediatric onset epilepsies, they do decrease as they get older. I'm an adult epilepsy specialist, so I tend to see people who maybe have started in childhood and then seizures have continued, or they have new onset seizures, never had one before, it's their first one ever, and then try to treat that. And really understanding what is the underlying cause for their seizures, for their epilepsy, really helps guide the treatment. What medications we choose, how we choose to give that medication if there's devices, and having all of the techniques at our disposal to really understand the cause of their epilepsy, like having a 7 Tesla MRI, actually helps us improve the treatment dramatically to make sure that they get onto the right course.
And I was actually going to ask, when you're looking at your patients, can you kind of walk us through what some of those causes are and then what their specific treatment would be?
Sure. So probably one of the most common pediatric epilepsies is what's called a primary generalized epilepsy. And it starts in usually in grade school, and sometimes they just have little spacing out, what people call absence seizures. In the old terminology, it was called petit mal, just losing attention for 2 or 3 seconds. Those events would be common, and then having the big classic generalized tonic-clonic seizure in that population, thankfully, is rare, but that's also part of that condition. And those patients tend to respond well to specific medications. Thankfully, low doses, but there's a lifelong risk, so they have to stay on those medications. Another possible cause is, interestingly, your birth order. It also increases your risk for seizure. So firstborn children are much more likely to have epilepsy than anyone else. And partly that's probably due to first-time moms back in the day not really having a lot of prenatal care and not really being aware that they were pregnant. And unfortunately, the development of the brain happens very early in a pregnancy, like in 6 weeks is when the brain starts to be set down. Mm-hmm. So if there's a lack of folic acid, which is one of the most important things in prenatal vitamins, there could be malformation of the brain forming in utero. And that puts people at risk for having seizures. It's just otherwise healthy brain tissue in the wrong place. And that creates a little network and an organization that increases risk for seizure. And in my experience, that population tends to start having seizures in early teens, usually around the time of puberty with hormone shifts. They have a tendency to be extremely resistant to medication treatment. They just don't respond to most of the medications that are on the market. There are a few that they respond to better. So if I get a clinical history that is suggestive of that for me, I'll put them on one of those medications. But it would also be nice to have imaging where we could see it, because those are some of the ones that are really small, that you just can't see on a 1.5T or a 3T. And then probably the next most common population in terms of seizure are people with scar tissue in the brain. They've had a traumatic brain injury in the past. They've had an infection, meningitis, that has left scar tissue in the brain. They've had a stroke. They've had a brain tumor. They've had a bleed into the brain. Any of those structural changes can then become a source for seizure. Like that scar tissue or the old blood in the brain just acts as an irritant if it's sitting next to normal neurons. And eventually those neurons start to seize. And a seizure is essentially just an abnormal synchronized firing of the neurons. The neurons are normally all just doing their own thing. And if they're all firing together at the same time, that's a seizure. So it's common.
Yeah.
It's like 1 in 22 people will be diagnosed with epilepsy at some point in their life.
Wow.
Yeah.
I didn't realize it was that prevalent.
It is. It's also still, unfortunately, carries a lot of stigma. So people don't tend to talk about it. And you can't look at someone and say, oh, they have epilepsy. No, it's a completely hidden disease process that I have a lot of patients that come in and say they got fired from their job when their employer found out that they had epilepsy, because they think it's a liability issue, or they won't hire them if they think they have epilepsy. And then if it's not controlled, they can't drive. And that's extremely limiting in terms of working possibilities, but also just quality of life, having to be dependent on others for you to get around. And it's especially hard for a lot of the population that we work with who live in rural areas where they don't have a bus system, where they don't have Uber. If they can't drive, they're really stuck. Sorry, I got off track there.
Oh, that's all right. But that's why it's so important that you're doing this research, so you can detect it early and be able to treat them better.
Exactly. Yeah.
And so as we're taping this in June, where are you kind of at in the research process? I know you said the 7T hasn't quite arrived yet.
So we're having a weekly journal club as a group. We're reviewing all of the data that's been published about 7T at the same time that we're all developing research plans. So once the machine is installed and ready to go, we can just hit the ground running with research questions. And as part of the collaboration between the university and the hospital, both have been supportive of research questions being addressed. As I had mentioned previously, doing an MRI for research can be very expensive. It's like $300 to $500 an hour research costs. So the researcher has to pay that in order to do a research question. And then the hospital and the university have basically donated time to the researchers so that we don't have to upfront come up with that cost to get the preliminary data to then eventually get grants. And the time of the scanner is actually split. So it's in a clinical setting. We can use it as a clinical tool. We can order it for clinical care. That will be part of its time. And then the rest of its time will be research, also divided between the hospital and the university. So it's definitely going to be, I think, in use continuously as soon as it's hooked up, because everyone's ready to go.
Hopefully it stays in good working condition, because I imagine working on one of those is not cheap.
Yeah. I imagine, I don't even want to imagine what happens if it doesn't work, but they're actually hiring a physicist whose whole job will be to take care of this machine, run the machine, make sure it's happy. So
that's good. You got to have it in working order.
Absolutely.
So as far as your research and trials and things of that nature, do you know like what that will entail? The prior episode, he was talking about switching between research on animals before doing research on humans. Is that kind of the case with your study?
In my case, I don't really do a lot of animal work. The first project that I'd like to address is actually going back to what I had mentioned before about how the brain malformations can occur in utero very early, and those changes can be really small. So I actually have since I've been seeing patients with epilepsy for a couple of years here at Carle, I've collected a list of patients that I suspect have that as the cause of their epilepsy, but their MRI, even on a 3 Tesla, looks completely normal. And I don't think it is. So I have this panel of patients ready to go on the 7T to see, is there this malformation that we can see? And then some of those patients, if we see a lesion, then they would qualify to be considered for surgery. So the first step is the 7T, looking to see if it's there. Work that I'm doing with a postdoc is using this other technique we have called magnetic resonance elastography that looks at the structural integrity of the tissue to see if we can use that to also detect these malformations in the brain, and then to compare MRE with 7T, and then hopefully with surgical pathology. Once we have patients who undergo surgery, we can take the tissue out, look at it, and see what it really was, and then backtrack to the 7T to the MRE as a final confirmation. That's going to be a years-long process, but
I was going to ask, typically, how long does something like this take?
Yeah, it takes a long time. Yeah. I think it's the 7T imaging part will be a lot faster because we already have an identified population. And as I see those patients in clinic for their return visits, I mentioned to them we have the 7T coming, and I'd really like to get this new technique to better understand you. And they're all incredibly excited and eager to participate.
So what does the process look like for a patient? Because I recently got an MRI, and I assume it was one of the lower, caliber. So is it kind of a similar process, or?
It is. It's exactly the same in terms of process. Like, you don't want any metal on your body as you go into the room.
Yeah.
I haven't had a 7T performed on me yet. I'm sure I will as soon as it's here. But I have heard that with that strong of a magnetic field, if you go in like at a weird angle or you're moving around too much in there, it can make you a little nauseous. So as you're going into the scanner, it's just really important to remain perfectly straight and still and not move around too much. I mean, you don't want to move around much in an MRI anyway, but I've heard that it's especially important for the 7T. So that'll be I guess the one difference is the education on be straight and don't move around too much. And if you feel nauseous, push the little button and let us know. So.
And is that before they put any type of dye in you, or is that part of the process? Or
there is the opportunity to use the contrast on 7T. I won't need it for any of my research, but it's important for looking at structural changes, vascular changes, brain tumors, that kind of thing. The dye doesn't affect how people feel. It doesn't make them feel nauseous in the MRI. CT contrast can make people feel a little funny, but the MRI contrast doesn't. So it literally just the magnetic field can make you feel a little off balance if you're moving around too much in it.
So again, as we're recording this in June, how has maybe COVID-19 impacted how you're putting this together? Has it at all?
Well, in March, as COVID was getting crazy, we all had concerns that it might slow this process down. But I think it's a testament to the commitment of both Carle and the university that this was a priority. And it hasn't actually affected the timeline at all in terms of preparation or moving forward. That they're just really forward thinking, certainly I think the knee-jerk reaction would be to put the brakes on anything that's happening 1, 2, 3 years in advance. But if you're really going to move forward to become a resource for the community, a health center that is a choice and not just because it's near you, you have to move forward with these things. So I was very happy that it didn't affect it at all.
So we definitely hit a lot on epilepsy. So before we wrap up, Alzheimer's and Parkinson's, are you able to talk about how this research can help that as well?
So for a lot of the neurodegenerative diseases like Alzheimer's and Parkinson's, the process of the disease process is a loss of neurons, a loss of tissue. In Alzheimer's, it's loss of tissue in the temporal lobe. For related Alzheimer's-like conditions like frontotemporal dementia, it's loss in the frontoparietal area. And Parkinson's, it's loss of dopaminergic neurons in the brainstem. And with most neurodegenerative diseases, when you're trying to diagnose that just based on history or clinical information, you can't really diagnose that until the disease is really far along. In Parkinson's, people don't actually show symptoms of the disease until they've lost about 70% of the dopaminergic neurons. I mean, that's pretty far along before there's any symptoms showing. So Parkinson's, for example, there's an amazing opportunity here to try to look at people who might be at risk and see if you can detect changes long before there would be any changes seen clinically or by history. Similar with Alzheimer's. You have a significant loss of brain tissue before someone has a really obvious deficit in their ability to remember things or function in their life. So using a better magnet that you can see smaller areas, you can see better tissue, allows us to diagnose these people earlier. And that's important, not just from a research perspective, but from a clinical perspective. You have to know who these people are in order to begin designing interventions to prevent the progression or to prevent the disease in the first place.
Definitely, it's important work that you're doing, and definitely hope to follow up in the next couple of months.
Yeah.
All right, well, thank you for being here, and thank you for joining us today for Being Well. We'll see you next time.
Thank you.
Carle is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carle, with Health Alliance, is always at the forefront to help you thrive.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. the ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.